My name is Megan Chumath, and I'm the Clinical Practice Initiatives Lead for HIV/AIDS for Vancouver Coastal Health. And like Scott, I'm a registered nurse as well as a public health person. And I've worked for many years, since 1994, which is really crazy. So I'm going to turn to now, why did we decide to redesign the HIV system of care? Well, we didn't decide. We got a memo about it and a press release. But we were really excited to have the opportunity to work on something that we'd been passionate about for many years. And I think if you were in any of the plenary sessions earlier today, you heard a lot about how the system was really designed for a different disease and a different epidemic. Thankfully, it's no longer the death sentence that it was. We now have the opportunity to really reorient services where they need to be. Mark Gilbert and I think also Chris and Scott spoke quite passionately also about the needs of gay men and other men who have sex with men. And in some cases, some of our services have been aligned in different key populations. And so we're also looking at how can we put them in the right prevention areas where the epidemiology is really showing us. But at the same time, how can we prevent patients who are falling through the cracks? And we know that happens really disproportionately for our patients with a high burden of mental health and addictions issues. So we also want to address that really unacceptable high burden of mortality and morbidity for our patients who are either coming to us with advanced HIV disease because they tested late or because they've really fallen through the cracks of the system. Julio already reviewed Gardner's Cascade with you, and this is something we had used. Actually, I think Dr. Tu brought forward to our group quite early on about a way to conceptualize our work. And you see, this is the old US numbers of less than 30% of people are actually accessing care in the magnitude to reach the full benefit of antiretroviral therapy and achieving suppression. And in Vancouver, Julio presented some data suggesting we're more at 40 to 50% currently, but that still means that half of our clients are not fully engaged to the level that they could be. So our first step, how did we get started in redesigning the system? We did, this is kind of a line list of what we did in our first 6 months. We developed a service inventory. It was really amazing. I was in charge of doing this in a booklet format, and I sent out an email asking people, what do you do, what populations do you serve, and how many clients do you see? And the hugely different ways of capturing data became very evident. Everyone was using different indicators. Some people were reporting clients they'd ever reached versus very rigorous annual figures. There was also a huge variety of what we thought people were doing to what they were actually doing. And when we got all the service providers in the same room together, some of you were in those meetings, it was astounding. People were like, oh, I didn't know you did that. And, oh, I worked just down the hall from you, and I had no idea that you had this innovative outreach program. Or it became clear that we really hadn't been talking to each other and that we had kind of old, outdated ideas of what our different AIDS service organizations might be doing or what our clinical services were doing. We also looked at the epidemiology and built great partnerships with Mark Gilbert's team at BCCDC, as well as our own public health surveillance unit, some of whom are here. There's Ellen. We also reviewed access to treatment data that was available to us from the BC Centre for Excellence and really drilled down and looked at the different populations and how that access was looking. We commissioned some quick wins, which were not necessarily quick wins, but one of the successful quick wins was actually a literature review, which comes up as number 2, but was done by Dr. Sarah Fielden, who I think might be here, who's now the Provincial Point of Care Manager. But at the time, she did a really great literature review because we wanted to see what are some of the interventions that we could try. And I think that'll be available on the CATIE website, and happy to share with you. Another quick win we did was implement an electronic medical record system changes. That was not a quick win. Still not finished. But I still think quick wins is a nice way of conceptualizing it, but just be cautioned that they're not always quick. In terms of frameworks, many of these frameworks are familiar to you, such as the expanded chronic care model, but I'll just review some of them and kind of leave them with you in terms of answering. I think Amrit asked a really good question earlier today, like how did you get started? And these are some of the frameworks we use to really conceptualize our work and put it in categories so that we could measure it and analyze it. So next slide. This continuum of care model was actually developed by Dr. Rolando Barrios and was a a real early stage of the Stop HIV/AIDS project helped us conceptualize what it was that we were tasked with doing. And so we knew that we had to increase contact tracing and case finding. We had to increase early diagnosis and linkage to care. We had to retain people in care. We had to engage them in care. And ultimately, we were looking for a very hard, biological marker of reduced viral suppression or reducing HIV incidence. And this really, in some ways, was limiting because many of us came from the prevention world, the primary prevention world. And so it took us quite a bit to wrap our brains around, but what about needle and syringe programs? And what about condoms? And that's not in here. But we sort of all eventually came to the decision to sort of stick to the stop box, as we called it. And it was a challenge because it was a very tight box. But at the same time, it was an opportunity because anyone who knows anything about change management will tell you that really you have to have an achievable, measurable goal, and it has to be simple and straightforward. And really, we were able to start to conceptualize our work as it's about testing, engagement, and care. And that was it. A model that many of your organizations already use is the expanded chronic care model. This kind of newer to apply this to HIV because HIV, the idea that it's a chronic manageable condition comes with all of the advances with treatment, but we've since been really looking at it and taking it outside of strictly the communicable disease control realm or public health and really moving it into as well our primary care systems and our chronic care systems. And I'll, in my presentation, go over a few of the key headings, but for me this model really resonated because it also has the opportunity to work on the policy issues, the real structural drivers of HIV, as well as the social determinants of health in points of the model that suggest you need to create supportive environments, you need informed and activated patients. So this eventually led us to the next model, which is on your table, just because it's so hard to see. You each have a copy of it. And this is a newer way that Sue Laughlin's teams really helped us conceptualize our work as a client journey. And it's really about taking a client-centered approach and looking at clients through their process of entering our care and really integrating and coordinating our care system. In some ways it can look like silos, and that's a big part of our work is now, describing what we do, but how are we going to meaningfully integrate it? And I'll talk about that a little bit. Thank you. This was the sort of care escalator that Scott Harrison actually brought to the table. Again, not necessarily a new idea, but it helped us really look at our service delivery system and think about, is it really aligned to meet patients' needs? Or do we still have so Mark presented data about the percentage or prevalence among people who use injection drugs is really going down, and the prevalence in men of sex with men is going up. And we found in the Vancouver system anyway, we had the majority of our services oriented towards the 1990s sort of epidemic of people who used injection drugs, and really not a proportional level of service oriented towards gay men and men of sex with men. So part of this has been sort of slowly turning the system, but also recognizing that there are vulnerabilities at that level of mental health and addictions that require really intensive support. And so we've worked really hard at trying to conceptualize this care escalator and the idea that people can move up from needing general levels of support to episodic to intensive. For instance, some clients might be very well managed in community, have a very strong support network, a lot of resiliency, good friends, good community, managing with a private GP, engaged in self-management groups. They might be leading self-management groups, volunteering, working, and they might develop a crisis. They might lose a family member very close to them or suffer from a mental illness and jump into the episodic box, but it doesn't mean they can't go back down into the general box. And so really working at our intake procedures so that we're putting people in the right service at the right time, but that we also got a discharge plan for them so that they can go back into their community of care that's appropriate to them as their illness changes. And we also know that some folks, for instance, some of my clients that I've worked with for many years, might suffer, for instance, from fetal alcohol syndrome, have some decision-making issues, will probably always need quite an intensive level of support, but that doesn't mean we can't be continually working to support them to have self-efficacy and to have self-management skills. A big part of the chronic care model is also clear leadership, and you heard if you were in the last session or earlier today that STOP Project really did have a very, in some ways, distributed leadership by having the 3 project sponsors, so Scott Harrison, Chris Buckner, and Val Monroe. But we also had the real opportunity for community to have input into our work, other clinicians from the front line and the services, as well as people living with HIV as much as possible. Something we can always improve, but we've tried. And then this point, I don't want to belabor because I think it came out loud and clear in many of the sessions, but the importance of measurement to really drive change. And this was, I was working on my slides and got a tweet from a friend about Bill Gates' new letter in the Wall Street Journal, and I thought it was quite interesting. He was actually talking about his biggest lesson of how to change the world, and he wasn't even just speaking about health, but his biggest message to world leaders about how to drive change. And he used the same point that we've been belaboring over and over again this morning, which is that you have to use data. And he drew this parallel between the steam engine being one of the most important innovations in the 21st century, and really what changed the steam engine, which really allowed it to move forward and get faster and better, was when someone invented a gauge. So simple. But until they invented a gauge where they could measure change, this much coal makes you go faster, it does not, that was how they were able to move the system forward. And without this feedback from these precise measurements that they could see on the gauge, the system was really doomed to be rare and erratic, and invention could not become commonplace. So that's kind of a weird example of a steam engine, but it applies to our work. And one really practical example, I can show on the next slide, is my original failure of 2 years, which was like the steam engine with no gauge, was the blue line. So you see, this was Dr. Gustafson and I going out to our VCH primary care clinics and having passionate speeches and saying, could you please start doing routine HIV testing? And I could see some of my colleagues nodding because I came to those talks, and everybody would nod and say, yeah, we really need to change. But they would just walk away and go back to their regular clinical practice. And I still practice as well, and I know how hard it is to make changes to your practice. It wasn't until kind of where the star is and the orange line, and then the later black line is 2012. That was when we started getting data to people and putting in front of them, these are your testing numbers, because we heard again and again, we're already testing. Thanks very much, we do testing. Of course we test everybody. Why would we need to change it? It wasn't until we said, well, you have 2,000 patients and you've only done 20 tests in the last 2 years. Who are you testing? Oh, really? I thought we did more than that. And then it was like, what do you want to do? And letting them set their own targets. Okay, we want to set our own target of 50%, or we want to set a stretch target of 90% of tests. And then we really would like to see the results. And so getting back to them in a month or 2 months with, this is your data, this is how you've been improving, and then really owning that change and making the decision at the local clinic level how they were going to implement it. And everybody had very different strategies. So it was really exciting to be able to share with other teams, well, this team did this. They had a requisition and they kept a pre-ticked requisition next to their regular requisitions. If someone had HIV, they could grab one, or someone wanted HIV test, they could grab that one. Others implemented it into their electronic medical record, a routine reminder, just a huge variety, stickers, and we have some sort of tools that we're happy to share with you and will be available on the CATIE website as well. But that was really a concrete way for us to drive change. This is a concept by the project team where they've just drawn up their system of similarly using data to drive performance in our memorandum of understandings with our community and our direct clinical partners. So Chris mentioned having 6-month MOUs with people, and we really did set targets with them. How many people are you going to engage in care and treatment? How many people are you going to support? And ultimately using those CD4s and viral loads as the sort of objective measures of success, which is really challenging conversations with ourselves and our partners, is what we're doing actually working. And sort of, it also allowed us, though, to be very transparent in our goals and to sort of say, we're in this narrow stop box, sorry, but if you haven't been making an impact on your clients' clinical markers for whatever reason, we need to reorient, or we need to support you. If it's the complex social determinants, how can we get more housing or support you to be engaged in the housing system so that you can actually make a change in these really objective clinical measures. And it became, as someone that doesn't really come passionately from the biological kind of medical science, it come from a more social justice framework, it was really challenging, but ultimately really rewarding, because it allowed me to advocate for things like housing that I knew made a difference in those biological measures, and was able to get traction on on some things that I considered more structural drivers of the epidemic. In terms of delivery system, it's also mentioned, but just really actioning that old concept of every door is the right door and having one-stop shop models where people could get everything they needed in one place. And that meant really collapsing the hierarchy between community and healthcare and saying, if we're going to work together, why not embed clinical staff in the Youth Co site so that when a nurse comes to Youth Co can go to the drop-in where they've got really great food security support and can pop into the side room and get CD4s and viral loads for folks and catch them up on their disease monitoring and do a primary care assessment, refer them into detox if they need it. And why can't that occur at the community agency level? Why does it have to always be about patients coming to us? But it also meant in our clinical sites having actual peers engaged with us. So this is a picture of Gabe from the Positive Living BC Peer Navigator program with some of the outreach nurses from the STOP team and also our outreach worker, Carrie. And we really had some challenging conversations with Glenn and others about confidentiality and privacy and are we allowed to have peers in the clinical rounds. And I took quite a hardline stance, like they're in or they're out. And we had these conversations and actually ended up getting a policy to back us up that no, they can sign the same confidentiality agreements that we sign. They can be at the table. They have to, if they're real partners, they need to be there for the clinical rounds and they need to hear these discussions because otherwise they won't be having all the same information that the clinicians have and it's not true partnership. So we had some good success moving that forward. A couple minor points to wrap up around decision support. You heard a bit already today about the Provincial HIV Collaborative. That's been a great success. It's also an example of data driving change, but also clarifying for folks what are the best practices in HIV primary care, what are the guidelines, and setting our own sort of measures as a collaborative. If you don't already have teams engaged in the collaborative, if you have a clinical care team and they're not in the collaborative, I encourage you to reach out to Christina Clark and Rolando Barrios about joining the next stage of the collaborative. We also found really the need to standardize our clinical information systems. One of the best successes of embedding a Vancouver Coastal Health STOP outreach nurse and some of our community partners like Vancouver Native Health meant that now that nurse embedded could get a simple thing like a VCH computer. And by having a VCH computer, they could access Care Connect, which is our way of communicating between acute care and community. And by having access to that, they could look at x-rays, they can look at lab results, they can look at the discharge summaries from the specialists in acute, and they can share that with their care team in a community-based agency. Huge improvement in continuity of care, and was really a huge benefit for us to have that embedded in our community agencies, even our aid service organizations. Just a practical example. Next one. This is just a photo of some of the data that we were collecting in the collaborative. It's a bit hard to see, but I encourage you to reach out to Christina if you want more data. Self-management. This is, I think, largely due to Glenn's leadership, and he'll have a table here that you can go and speak to him about. But working with the Positive Living BC Peer Navigators, again, can't say how great it's been. We also had peers involved from Vancouver Native Health that Dr. Tu can talk about. Peers in Positive Women's Network and many other agencies, our African Women's Group, and really taking the time to fund some self-management groups where people can get together and talk about their own experiences and share their own knowledge. This is also, I think, an area that we could improve on and something we're kind of working, looking at in our future state models is how do we really integrate self-management into all of our programs. And IDC's shown a lot of leadership in that area, so look forward to spreading that and what we know about other chronic diseases like diabetes and how we can start to integrate that into our HIV systems. Next one. Creating supportive environments, another cornerstone of the chronic care model. This is a picture of our housing partnership with Coast Mental Health, where we, of course, didn't have the funding to build a new building, but we actually were able to purchase priority access to 25 housing units of a new building by embedding some housing support workers into the building, and that's been an invaluable partnership for our STOP outreach team, as well as supported independent living subsidies with Rain City and McLaren, as well as priority access to shelter beds. So sort of, again, conceptualizing that care escalator of intensive and the more episodic in general, focusing on some needs for folks in the episodic level as well as the more intensive from homelessness, really street level into shelter, and then hopefully moving people along. It hasn't worked as perfectly as we wanted because that continuum gets blocked, which is part of this. How do we work on discharge plans and moving people to the appropriate level of housing? Thanks, Lynn. And again, this for me encapsulates our campaign called It's Different Now, which was something we wanted to invest in. And for me, it was really a stigma reduction campaign. It was in some ways about routine HIV testing and readying the ground for providers, but we also wanted to get the message out that people living with HIV could live long and healthy lives if they were diagnosed early, and that they were partners in our sort of transformation. So this was an interview with Denise Becker, who's a woman living with HIV for many years, and she was an excellent advocate with us. And there's a lot of people talk about stigma, and it's like a mountain that you can't cross, but there's so much you can do. I mean, I take many lessons actually from the work I've done internationally, and others have probably done in Africa, but there's very real, concrete ways of addressing stigma. It's policy change, it's having legal support for key populations. It's the, they call in Africa proximity, which is putting people living with HIV with people who never had met someone before. And that act of having people living with HIV speaking about their illness and their ability to manage and really being that face is hugely powerful to break down barriers for the care providers. We heard some physicians, Scott was I thought you were being quite nice in the acute care talk earlier, but we actually had some people say, why should I care about a disease that's someone else's fault for getting? You know, and these are like educated specialists and surgeons, and that's really still out there. And so we have to address it head on. And that's really hard to say when you're sitting next to someone living with HIV, and that's really once you get to know them. And if you haven't worked in this area for a long time, you need to learn that these are people's brothers and sisters and patients, and sometimes your own colleagues, they're physicians in the room. I mean, some of the things that we hear, you're like, I happen to know that many people in this room are living with HIV, not out, and people are being so disrespectful. We heard also a real passionate plea from Michelle today, and Idle No More, and the sort of same thing with the racism that we have in our healthcare system, but absolutely unacceptable and things we have to challenge really head on. And so I think I belabored the stigma point. Others talked about competing priorities. We had some questions about that in our last session. How do you implement this? And sometimes I would go to a group to passionately plea about implementing routine testing in a place you'd think it would already be. Our detox, it wasn't there. Our mental health and addictions teams, no testing was going on. And they would say, oh, the smoking people are on right now. You've got 5 minutes. Next, we've got the obesity people. So you're kind of in the line of everybody else. And even in our own work, if this is, for me, I'm lucky that it's my full-time job, but this project isn't my full-time job. There's other projects. So it's sort of doing this off the side of the desk, and again, having the support of the project team that many others have echoed has been huge in that, and keeping us on track and working with the right mix of skills, because my skill is not being hyper-organized and ticking off spreadsheets, but I've been really fortunate to work with colleagues that is their skill, and I've learned so much from them, the analysts and the epidemiologists, and even really brilliant admin assistants. Love them. I'm sure you hopefully know that already, but they are so helpful. Again, implementing new and targeted funding has been a challenge in this environment of scarcity where we're not used to new dollars. I did in the early days get a lot of emails about how an MRI machine was directly connected to HIV, or don't you want to fund our this and this project that people were dusting off all these old proposals here, and this could be an HIV project. So we had to kind of hunker down and say, we've got to do our assessment phase, we'll get back to you. And then again, that complexity of addressing these social determinants of health that really underline this disease, and using the data to, in some ways, fight for those and to fight for the changes that we need for our patients. So the next steps for us, just to wrap up, this is a beautiful picture done by the project team about our future service delivery models. So you see on your table, you have the patient journey through prevention, testing, care, and treatment and supports. And this is really about our effort to try and integrate it and describe it as one model of care. And we're actually kind of costing out and planning, how many staff would you need to have the different care escalators served in ARV adherence support, in case management? What does a self-management program look like in our future state for HIV services, and how is that integrated into our kind of existing primary care and acute systems? I'm also really encouraged that Hope to Health and jealous for you guys that you have this opportunity also to have a goal on prevention, because that was something that's recently been added that we didn't have, and so again, really reinvigorated to look at primary prevention and consider not just treatment as prevention as the only kind of arm of our strategy, but also addressing social justice and human rights, as well as the need to really still meaningfully scale up coverage of things like needle and syringe programs. And we know from even man count that 30% of gay men mentioned that one of the reasons they didn't use a condom because one wasn't available at the time. And in this day and age, that's really something we need to look at. Why do we not have condoms everywhere? Why do we not have needle and syringe programs available in the middle of the night wherever you are? Because that's also unacceptable. So just to summarize, my last slide, the lessons learned. Use data to drive your change, but also don't forget the art of storytelling. So I think today you've heard a few different stories, but I can't describe how powerful it has been to have our medical health officer, Dr. Gustafson, come with me to meetings and to have people just kind of looking at their Blackberries, and then she pipes up with, today I diagnosed a 16-year-old boy who'd only ever had one sex partner, and today I diagnosed a 29-year-old with who'd had 19 blood tests, and he had not yet diagnosed viremia, and he'd been in multiple hospitals across our province, and finally he got offered an HIV test because he got admitted to us in a routine test. So that was really what drove the change with the clinicians, as well as the data together, that sort of magical combination. And that allowed us to really change sort of the hearts and minds of folks in Vancouver. And I'm sure that's something you already employ in your own work. Many of us have spoken already about the importance of a population health approach and having, I think actually Nellie said this to me the other day. I was talking about one of our services that said they were full and couldn't take any new intakes, and she said, we have just as much of a responsibility to people outside our door as those inside. And that's a really new way of conceptualizing our work. When we keep our head down and we're like, we are serving these people and we just can't possibly take anyone else on, and really thinking, nope, that's not acceptable. If we're taking a population health approach, that's not going to work. Resisting the new and shiny. I think you do have to sort of throw out what you think you're going to do on one hand, but there is also, which Dr. Jean Ogilvie spoke eloquently to today, a need to expand capacity of sites that are working, that have meaningful relationships with people living with HIV already, that are doing good work, and you need to expand. If there are ones that are full after you've looked at their systems of intake and discharge, would it make a huge difference for them to have some additional physician sessions or some additional nurses or outreach added to their service? And many times it would. So it's about also really engaging with existing providers, and then really keeping clients' needs at the front and center, and the patient voice, and engaging meaningfully with people living with HIV and taking the time to hear from them what they need, but also bringing them to the table and as full partners and as care providers, which is part of what we've changed now. So that's the end of my soapbox, but I'm really excited to spend some time with all of you in some small group work. So we're going to have a World Cafe style marketplace of ideas, which the CATIE folks kind of killing me for because we can't film it properly. But I just wanted to get out of I was worried we were getting panelitis, I called it. I said, like, we can't film it. I'm like, we have to get out of the panels. So we're going to work in small groups. And at table number 1, I'm excited to have Glenn, who I introduced earlier, talk about peers and the role of peers in redesign. At table number 2, we've got Mary talking about the integration of acute and community care. Table number 3, we have Dr. David Tu from Native Health, talking about the chronic care model. Table number 4, we have Miranda Compton talking about practical tips. She's our real operational manager, so she's got some practical examples of system redesign. And then table number 5, we have Glenn Dupé from BCCDC talking about the public health system and how they've sort of reoriented and made changes there. In terms of format, we're going to spend 10 minutes at each table, and then I don't actually have a bell. I forgot it. But I'll come up and let you know when the 10 minutes are up and when it's time to move, and if you could just move ideally from table 1 to 2 and kind of go in a bit of a circle so you have a chance to spend time with each of the facilitators. Some facilitators will stay. It's just a really open format for you to ask questions, but also share your own experiences. We're hoping you'll get some thoughts up on the whiteboard that we can sort of share and write up and summarize. And I am going to also add a little caveat of the 2 feet rule, which is that you're all adult learners. And so if you're at your table and you're like, oh, this discussion doesn't apply to my work, or you're at a particular table and you do want to stay there, you can do that. But I also encourage you to spend some time with each facilitator and also get the chance to meet everybody and meet each other. Great. At the end, we're going to have a wrap-up, a rapporteur session with Scott, and Scott and Lynn and I will be kind of eavesdropping a bit on your conversations and moving around, just kind of gathering some of the themes. And then I'm going to let Scott also say a few words.
As you're doing this work this afternoon, and as you've heard everything today, and as you hear everything that you'll hear us talking about tomorrow, please keep in mind that what we said this morning rings true, is that it's about sharing what went wrong as well as what went right. Otherwise, it sounds like we've just all drunk the Kool-Aid, and I can promise you we haven't. And I hope and pray that you don't all drink the Kool-Aid as well. When you're thinking about system redesign, think about unintended consequences, because it's something that we didn't necessarily think about, and we've had to learn from that. So who wants to hear a failure story? Everyone likes the dirt. Routine HIV testing in dental practices. No. It had such promise, and it was such a failure. Didn't work. So we tried. We thought it was a novel approach, and that was never going to fly. Didn't work for us. The more serious unintended consequence of STOP has been the creation of a new level of person, which is the unsuppressed. And that's something that I really urge you to all think about seriously. Our job in HIV care is to not further stigmatize people who are living with HIV, and one of the unintended consequences of STOP is that we have re-stigmatized groups, and we've created a whole new level of HIV, which is the unsuppressed. When you listen to the data, have that in mind. I took offense this morning at hearing one of my own colleagues describe the data around MSM, because the data is put up on the screen, but we need context around data. Yes, the rates of HIV may be higher, but what isn't discussed is how systemic homophobia and bullying and social exclusion affects the sexual behaviors of people that then affect their risk of HIV. And it's the same as Michelle spoke passionately about with Aboriginal communities. We present the data without it being framed and put into context. So always have that in your mind, that there are good things that we do, and there are unintended consequences.
Great thing for discussing in our small groups. So I'm going to invite people to stand up and go towards a table. If you could try and balance it out, remember you'll get a chance and start your first 10 minutes. Thank you.